Greetings, I'm Dr. Ron Lewert. Welcome to my YouTube page. This is my Whiplash Associated Disorders lecture. It is a review of the recent evidence-based research, mostly pertaining to factors which are associated with poor outcome following whiplash. If you're an insurance adjuster, a paralegal, or a personal injury attorney, you'll be interested in this presentation as I review nearly 60 references to the peer-reviewed literature on the topic. So it is my intention with this presentation to clear up some of the controversy that exists between insurance companies, treating patients and their representing attorneys, as well as treating physicians. Some of those topics include vehicle damage versus the potential for occupant injury, mechanisms of injury, which treatments are most effective clinically as well as cost effectively, and does whiplash present itself as a self-limiting condition, or can it produce chronic pain? The purpose of this presentation is to provide you with an updated and factual understanding of our evidence-based literature on whiplash concerning a number of topics here. So the first thing that we're going to look at are the injury models, how people get injured, and what is the mechanism of injury in whiplash. The second thing we'll look at is the role of tissue damage. Which specific tissue injury sites are responsible for acute and chronic pain following whiplash? We'll look at some of the diagnostic imaging shortcomings of plain film X-ray and MRI, as well as the physical and psychological factors associated with poor outcome. So who suffers chronically after their whiplash injury? We'll discuss invasive versus non-invasive treatments, and something called matched interventions. So what does the research say about specific treatments that are most effective in treatment of whiplash? So let's get into this a little bit and discuss injury models, how patients get injured in a rear impact collision. So there are two injury models. The first is a kinetic model. It describes the transfer of energy from the striking vehicle to the cervical spine of the occupant in the struck vehicle. It's basically transfer of energy, blunt force trauma from the vehicle into the neck of the struck vehicle's occupants. The kinematic model involves abnormal physiologic movements that occur in the spine as a result of the vehicle being struck and moving beneath the occupant. So if we take a look at this guy over here, you see his normal cervical lordosis is a C-shaped forward. That's for most of us. The vehicle movement is in this direction here. So being that this person is seated and stationary, the movement of the head once the vehicle is struck relative to the vehicle is in the opposite direction. So we have shearing forces. Shearing forces can cause some significant damage. And as you'll see, when the vehicle strikes the lower portion of the cervical spine here, it pushes these vertebrae forward. It changes the shape of the cervical spine from a C shape like this to an S shape like this. And these abnormal movements in the spine have the potential to produce very significant injuries to very specific structures. What are those structures? Well, we'll take a look at that on the next slide. By the way, this is Nikolai Bogduk and Michelle Curtolo's work. I advise anybody interested in this topic, you pull this article and read it. It's very interesting. So going further with injury mechanisms and the potential for very specific tissue injury sites, if we look over here, the vehicle has been struck from the rear. The vehicle movement is in this direction here. The occupant's head will undergo horizontal shear, so we have head movement in the opposite direction of the vehicle movement. And so this head moves slightly rearward towards the seat back, and the torso moves forward as the vehicle moves beneath the occupant. The resultant rapid change from normal convex C shape in the cervical spine to an abnormal S-shaped curve produces stress loads which exceed physiologic limits of specific tissue sites. We are yet to reveal those, but we will shortly. What we're looking at are the potential for tears of the facet capsular ligaments, facet capsules, multifidus muscle groups. The attachment of the intervertebral disc to the end plates have also been verified and documented. And if we reference Bogduck and Curtolo's work, they state, and I quote, "There is evidence of a lesion-based model in WAD. Lack of macroscopically identifiable tissue damage does not rule out the presence of painful lesions. Facet joint and zygapophyseal zygapophyseal joint lesions have been validated, and they are treatable. The lesions account for a large portion of patients with chronic whiplash associated disorders." So if we're looking at injury to the facet capsular ligaments, the multifidus muscle groups, and the deeper structures, including the intervertebral disc, these injuries account for a large portion of patients who are experiencing chronic pain following their whiplash injury. So in the previous journal reference, Curtolo and Bogduck reference very specific tissue injury sites that can result from whiplash. So carrying that a little bit further, we see specifically injury sites are as follows. We have the facet capsular ligaments and the facet joints, the multifidus muscle groups, the synovium and cartilage, as well as the vertebral end plate connection to the disc. The abnormal physiologic motion, where we see the change from the cervical lordosis to the S shape as the vehicle moves forward, has also the potential to produce some pretty nasty injuries here. We're talking about ruptured discs, herniated discs, complete or partial rupture of the facet capsular ligaments, that's these structures here. We can see transarticular synovial fractures, facet joint fractures, partial rupture of ligaments, and deep tissue muscular injuries such as tears of the multifidus muscles. So these references are here again to illustrate for attorneys and insurance adjusters if you so desire. These are very good articles to pull up and review. So these additional references to the previous slide here further substantiate the chronicity or the potential for chronic pain when we have an injury to the multifidus muscles, intervertebral disc, or facet capsular ligaments. And I quote, "These injuries lead to modification of tissue properties. So the tissue damage actually changes the function of our tissues to produce nociceptive or pain activation, sustained dysfunction in spinal afferents, again, that is a chronic signaling of pain from the injured tissue, neuroplastic changes, phenotypic switching, and central sensitization." These terms imply memorization of pain and upregulation of our pain experience. And we know that many patients who experience a severe type of whiplash injury have poor outcome with the potential for fibromyalgia-like chronic pain. So that's what this is all about here. So in addition to injuries to the intervertebral disc, which are obviously seen on MRI scans, injuries to the multifidus muscle groups and facet joints, as well as the facet capsular ligaments, are not routinely seen on diagnostic imaging or plain film X-ray. However, if we quote Bogduck and Curtolo, this study here, we can state that there is multi-study collaborative evidence of pain nerve activation, abnormal tissue healing, which they say abnormal collagen production and collagen fiber disorganization, axonal swelling, potentially nerve root damage, producing radiculopathy, and permanent nociceptor signaling in the spinal cord following forces applied to the facet joints. So this is something that is not seen on plain film X-ray or MRI. However, we have these changes in function regarding the tissue site and the tissue injury. For whiplash-associated disorders, all lesions to the facet joints are induced in the absence of grossly observable evidence of rupture or tear. It's very interesting. These observations provide pivotal basic evidence that cervical zygapophyseal joints can be damaged by whiplash and become a source of chronic pain. So for the insurance adjuster, those patients who are experiencing chronic pain and you're holding a normal MRI scan result in your hands and observing this patient over the course of several months, possibly treat with chiropractor or an orthopedist or undergo physical therapy, and have some pretty nasty complaints along the way, likely that in the absence of a disc injury, they sustained an injury to the deeper structures, such as the facet capsular ligaments or the facet joints. And you should see correlation between the patient's range of motion, mainly in extension and extension rotation. If we do a facet loading maneuver on that patient, it should reproduce their pain. That maneuver will also reproduce disc pain. But in the absence of an MRI, we should see that they have a positive facet loading maneuver. They'll have restrictions in lateral bend. They'll have painful restricted ranges in extension. They may have some radiating pain into the shoulders because the facet joints can actually refer pain into an upper shoulder arm distribution depending on the level of facet joint. So we're looking at the potential for symptoms in the absence of grossly observable damage on clinical imaging. So on previous slides, we illustrated that there are numerous injuries that occur to the facet capsular ligaments and other deep structures which do not show up on conventional plain film X-ray or even MRI. So here's an example, excuse me, of an obviously visible disc herniation at C4-5. This is number 2, 3, 4, 5. So this is a C4-5 disc herniation with ventral thecal sac impingement. That was on this person's report. However, additional injuries that are documented on the report include questionable injuries to the anterior longitudinal ligament, which is placed here, and an injury right here, which we don't see, something called a rim lesion, which is basically an avulsion of the anterior vertebral end plate and annulus. So we have trauma to the vertebra with microscopic tissue tears that do not show up on plain film X-ray or MRI. And that's just a further illustration that some injuries, although present, do not show up on our current technology. We still have limits in our technology in identifying and illustrating some of the deeper injuries associated with whiplash. So regarding cerebrovascular accidents or arterial dissections following whiplash, we note that with these references here, Hauser and Demarin, they illustrate that the upper cervical spine, if rotated during a rear impact collision, in the right patient, the predisposed patient, possibly with type 2 diabetes, an obese patient, or someone with peripheral vascular disease or carotid artery stenosis, even patients that have severe cervical spondylotic myelopathy, spinal stenosis, or severe cervical degenerative disc disease may potentially sustain arterial injuries in a rear impact collision. In fact, onset of cerebrovascular symptoms may occur 4 to 12 months post whiplash injury. So what we need to do with some of the patients that have risk factors is auscultate the carotid arteries. Okay, we need to do vertebral artery screening on them and a full examination, including cranial nerves and cerebellar testing, so as to screen them for any potential cerebrovascular involvement. Some additional injuries which are also supported by scientific evidence, however, are not seen on routine plain film, emergency room X-ray, or MRI, are injuries to the multifidus muscle groups. And we mentioned the multifidus muscle groups as a potential for chronic pain following whiplash. And that is because the multifidus muscle groups attach, and here they are right here, directly to the facet capsular ligaments. We know that with facet capsular ligament injury, we have the potential to produce chronic pain. So, whiplash may produce injury to the muscles as a result of imposed abnormal lengthening. Remember the change in the normal cervical lordosis into that S shape. Well, these are abnormal physiologic movements that produce tissue tears. Here is an example of one of them. Trauma induced to the zygapophyseal joints or the facet joints may induce abnormal signaling from the mechanoreceptors, thereby producing muscle spasm and as a protective mechanism. So this can result in reduced range of motion, abnormal movement patterns, and the generation of chronic pain. So the multifidus muscles are somewhat unique. They insert directly to the capsular ligaments of the C4, so that's about mid-cervical spine to C7, the base of the cervical spine. And they may also tear and intensify the facet capsular ligament injury. So these are significant injuries that occur, again, in the absence of visualization on your MRI. So if we're interested in some of the additional injuries and lesions that can occur that are not identifiable on MRI or plain film X-ray, we see injury to the structure here not very often, called the dorsal root ganglion. More often what we're going to see is injury to these structures here very close to the spine or impingement of the cervical nerve roots. And we've all heard the term cervical radiculopathy. Well, we can have stretching of the nerve roots, or we can have a compressive injury from disc material sitting close to those structures. With regards to a dorsal root ganglion injury, which is very rare, we see rapid changes in fluid movement and pressure gradients sometimes created in the neural tissue, which can initiate tissue breakdown and lead to damage of neuron cell bodies. So here's your reference for that. This, if I were to emphasize anything on this particular slide, it would be the nerve root type of injury, and that is more common than the dorsal root ganglion lesion. In conjunction with this particular slide here, I'm going to ask that you go to my YouTube page and take a look at my lecture on intervertebral disc and how spine trauma can lead to degenerative disc disease. In that presentation, I review the basic and functional anatomy of the normal disc versus that of the injured disc. So we'll go into a little bit of that here, but for purposes of saving time, I'll refer you to the other presentation that I have. So this illustration here is demonstrating trauma-induced tissue damage where the disc, this white thing here, has pulled away from its connections to the bone above. This is another illustration of the same thing, except a little more dramatic. So we have the bone above and below, here and here. This is the intervertebral disc, and you'll see microscopic tissue tears. This is a rim lesion, okay? So part of the ligaments that attach the vertebrae together are torn, and part of the microscopic connective tissue that joins the disc to the vertebral end plate are torn here. This material here is exiting the center. This is a herniated disc. So the trauma induced at these sites causes a release of certain breakdown chemicals or matrix breakdown proteins. So what we're looking at is matrix metalloproteinase. We're looking at changes in oxygen and in pH as a result of this trauma. And so what this does not allow for is the adequate production of a substance that draws water into the disc. That substance is called proteoglycan aggrecan. So we have tissue injury, we have a bleed into the disc containing breakdown proteins, changes in oxygen, changes in the production of proteoglycan, and all this amounts to is nucleus cell death. Okay, so this is very significant and not seen on any imaging, but this is the pathophysiology of disc herniation, and it's well documented in the labs. I'd like to emphasize this little segment here on 3.0 Tesla strength MRI. We have some really fabulous MRI technology these days. However, these lesions still do not show up on the most powerful MRI scans that we have available. Cell damage occurs at the periosteal attachments of tendons, ligaments, and joint capsules, and it results in the release of MMPs, matrix metalloproteinases, the sustained release of pro-inflammatory cytokines. Well, you've heard of cytokines with COVID-19, the cytokine storm in the lungs. This is basically the release of chemicals that are the result of inflammation. So we have this with tissue damage also in our spine. And the sustained release of these pro-inflammatory chemicals as well as the breakdown proteins is what results in the disc herniating. So as we mentioned before, some of the technological shortcomings of our current low and high field MRI are such that they will not pick up microscopic tissue lesions. So what we need to do if we would like to see a facet capsular ligament injury is order the MRI scan with fat saturation or fat suppression technique. And that is what these studies down here illustrate. So basically what we can do is we can see the facet joints, we can see facet synovitis or facet edema, or edema within the capsular ligaments, which indicates trauma, if we order the scan with this fat suppression. So that is a really good technique. If you're not familiar with fat suppression in visualization of the facets, all you have to do is contact your local MRI center and speak to the radiologist and ask them to possibly make any changes necessary in order to more clearly visualize the facets if you are suspicious of a facet capsular ligament injury. Your physical examination should correlate with the patient's complaints. They should have a positive painful neck extension maneuver or restriction in lateral bend, or more likely a positive facet loading maneuver, which is painful extension rotation to either side. So what does the research say regarding recovery following whiplash? Well, the Journal of Pain, let's go with that here. The Journal of Pain, the Journal of Rheumatology, and the Journal of Sports and Physical Therapy, Orthopedic Sports and Physical Therapy, is where all this information comes from. So cohort studies have demonstrated that recovery, if it occurs, takes place within the first 2 to 3 months following the injury, with a plateau in symptoms following this time period. However, a significant number of patients remain symptomatic for significantly longer periods of time. And this is due to injuries which occur to the deep anatomical structures that we reviewed previously, the discs, the facet capsular ligaments, and the multifidus muscle groups. So recovery following whiplash is dependent on several factors. Now this is interesting because physicians need to pay attention to this stuff. Patients who experience initial mild to moderate symptoms with mild to moderate activities of daily living intolerances will follow an initial reduction of symptoms within the first few months of the initial injury. And about 45% of these patients will progress to good recovery in less than 6 months. So what we're going to see is with mild whiplash, we should see a steady course of recovery in under 6 months. With moderate to severe whiplash, these patients present with initial complaints that are much more severe. They may present with some neurologic symptoms, post-traumatic headache. These are patients who've had an airbag deploy on them, or they were involved in a T-bone type of accident at an intersection, or a high-speed rear impact collision. So these moderate to severe whiplash type of cases initially follow a much different pathway to only partial recovery. And what they will have are moderate functional disabilities still present at the 1 year post-accident interval. That is very significant. These injuries do not clear up within a 4 to 6 week period of time in the majority of cases, and we should evaluate these patients initially based on their initial complaint severity and their activities of daily living intolerances severity. Now the last group here, these are the severe whiplash cases. I've seen many of these over the course of years where a person sitting at a light gets rear-ended at about 60 miles per hour. We've had cases here in the office where the seat back breaks, and following the collision, the patient is basically laying in the back seat. We've seen fractures, we've seen disc herniations that require immediate surgical decompression and intervention. So severe whiplash is not a good thing. The research predicts that these patients experience partial recovery, and they're going to be stuck with moderate to severe disabilities on an ongoing basis. So overall, the research predicts that 50% of whiplash cases will report ongoing pain and disability at the 12-month post-accident date. That's very significant. So here's an interesting study which correlates patients' initial symptoms following whiplash with difficulties at the 1-year post-accident mark. And so Sterling and her co-workers in the Journal of Physiotherapy here were able to conclude that those patients who came in with mild to moderate whiplash were still having difficulty with function and activities of daily living to a mild to moderate degree, which corresponded with their symptoms at the 12-month post-accident date. The patients who presented with moderate to severe initial symptoms following their whiplash continued to experience moderate to severe pain-related disabilities at the 12-month post-accident interval. So this is an interesting study correlating initial symptom presentation with outcome and functional deficits at the 1-year mark. So here is yet another stated method of evaluating initial symptoms and hopefully outcome following whiplash. So if we use some of these guidelines, I think this can level the playing field for attorneys and physicians and insurance companies. This information is relatively easily accessible, and I don't think the guidelines are unreasonable. I think they correlate fairly well to real clinical practice. So if we're looking at the mild to moderate whiplash patient, about 45%, according to this study, will present to your office with initial mild to moderate complaints. So maybe half of your patients, or a little bit less than half of your patients, have mild to moderate whiplash. If this group is going to recover, they recover within a relatively reasonable period of time, 2 to 3 months, hopefully less than 6 months. And if we were to score this patient, or actually able to determine and label them as mild to moderate, we would use this Neck Disability Index functional assessment. And patients have to score less than 29% on that in order to be tagged mild to moderate. So we also use something called a visual analog scale. So we ask the patient on a scale of 1 to 10 to rate their pain. And if the self-reported pain levels are less than 5.5, along with the less than 29% on the NDI score, again, we have a consistent mild to moderate whiplash group. So we expect them not to have post-traumatic stress, depression, or pain catastrophizing. And basically, we're looking at patients here according to the Quebec Task Force guidelines. They'll have neck pain, they'll have decreased range of motion, and they'll have tenderness to palpation. And we won't see many of these patients with hard neurologic findings such as pathologic reflexes or depressed deep tendon reflexes. Recovery for these patients is still reported at the 12-month post-accident date to give them some mild to moderate functional deficits. So this is a very reasonable method of assessing your mild to moderate whiplash patient. And so let's go on to the next group. So recovery for the moderate to severe group takes a bit of a different turn. So we'll see only partial recovery with the moderate to severe whiplash patient. These patients will come in with neck pain, decreased range of motion, a lot of muscular tension and spasm, very tender muscles to clinical evaluation and palpation, possibly some neurologic findings, decreased or absent deep tendon reflexes, sensory deficits, possibly some motor weakness. We can see patients with post-traumatic headaches. These are patients who have sustained a concussion from an airbag deployment, or they've struck their head in the interior of the vehicle, or they had a multi-directional type of impact. And these patients are obviously in miserable pain when they come into the office. So with partial recovery, we're looking at a course of treatments that exceeds that of the mild to moderate group. So we're looking at moderate levels of activities of daily living intolerances after a year still. These patients typically will have pain at the 4-week post-accident interval and have multiple, or at least one or multiple disc herniations on their cervical spine MRI. The neck disability index score are greater than 29%, and obviously we see scores on the self-reported pain scale of greater than 5.5. We may see some reports of post-traumatic stress, and we do have patients that have sustained a concussion. They have disturbed sleep, disturbed concentration, possibly emotional lability, and we may see depression in these patients because the symptoms are strong and they last for quite a significant period of time. So a smaller number of your patients will present themselves with severe whiplash. So if we look at their functional deficits, let's say the neck disability index here, all right, they're going to have a very high score, and they're going to tell you that everything that they do and experience is painful. These patients have self-reported pain levels that are much greater than 5.5. You'll see these patients are absolutely miserable. They have severe restrictions in range of motion, possibly post-traumatic headaches. They may have sustained a concussion. They may have gotten struck by an airbag or struck themselves on the interior of the vehicle. They can barely move their neck. You will find neurologic deficits on these patients, potentially in either sensory, motor, or reflex modalities. You will see definitely positive MRI scans with the severe group. If you order an MRI at the 4-week post-accident date, you're going to see one or multiple disc herniations. These patients will not respond to conservative treatment. Whether we apply class 4 laser, decompression traction, or if we're able to apply other modalities, these patients will still be in pain at the 12-month post-accident interval, and they will have severe activities of daily living intolerances at the 12-month post-accident interval. These are also patients that you may have to refer for neurosurgical consultation or for interventional pain management. Again, your therapies have not, your therapies have not fully reduced patient symptoms or been able to restore them to full function. So, which indicators of poor functional recovery can we actually count on? There is consistent evidence in the literature, we'll go down to this first column here, of factors that do not predict poor recovery. So we cannot rely on vehicle damage, either the presence of vehicle damage to indicate a severe injury, or the absence of vehicle damage where the insurance companies want to say that there's no injury. So vehicle damage does not equal injury in any way, shape, or form. There's no prediction of the potential for injury following whiplash or the potential for a poor outcome following whiplash based on vehicle damage. Additional factors such as collision awareness, speed of the accident, or the occupant's position in the vehicle do not predict poor recovery. And this is contrary to what many insurance adjusters argue with attorneys. We have other factors that are inconsistent in terms of predicting poor recovery. One of them is older age. Another is female gender, neck range of motion following the collision, or whether or not the patient has an attorney. There are some studies which discuss these factors as relating to poor outcome, but mostly there are inconsistencies in the data associated with these factors. If we're looking at consistent evidence for poor recovery with regards to physical presentation of the patient, we're looking at the severe whiplash patient or the moderate to severe whiplash patient. These factors here are all associated with the severe and moderate to severe whiplash patient. They have, this group would have post-traumatic stress, very high pain levels, and very high stated functional deficits following their whiplash injury. These patients may also have negative expectations of recovery or have sustained an injury such that they're experiencing cold hyperalgesia or pain catastrophizing. So these are likely patients that you've had to refer to a neurosurgeon or pain management specialist. These are patients who have not recovered fully with your conservative treatment. So this slide here references the previous slides. I didn't have room to list all of the journal references here, but these will support all of the comments in my previous slides if we didn't show a reference on that particular slide. So what are the treatments the research recommends for whiplash-associated disorders? Well, our matched interventions, which basically are modalities that achieve a specific purpose in clinical treatment. And for whiplash, what we need to do is we need to first penetrate to the deep tissue. We need to be able to reach the facet joint, the disc, or the injured multifidus muscle with a modality that penetrates. So if we're going to reduce the acute inflammatory response and put a halt to the microscopic tissue bleeding that's occurred, we need to use the class 4 laser as opposed to the cold laser. That's class 3B laser. We don't use class 3. The research recommends only class 4. We use the K laser here at Medical Consultants. We use manual therapy techniques, hands-on techniques, trigger point therapy, hands-on stretching. We have an intermittent traction or decompression traction, which is recommended. We also have that here at Medical Consultants. Neurodynamic techniques performed by therapists where we perform active and passive range of motion techniques are recommended in terms of treatment, as well as if the patient fails to recover completely from conservative care, facet injections or percutaneous medial branch ablations are also recommended and supported in the literature. What is not recommended in the literature in treatment of whiplash, at least on a long-term basis? And here the list is right here. We have electric stimulation, ultrasound, and interferential current. These are used every day in the treatment of musculoskeletal pain. However, they are not recommended for treatment, at least on the long term, for relief of symptoms associated with whiplash, nor do they penetrate to the tissue injury site. These modalities merely penetrate to the subcutaneous level. Superficial massage techniques or applications of hot and cold packs also do not penetrate to the injured tissue. So these are not recommended, these are not supported by the literature. So to summarize, there are two injury models for whiplash. We learned about the transfer of energy to specific tissue sites and the changes in the cervical lordosis from a C shape to an S shape. We learned the main lesion associated with whiplash is the facet capsular ligament injury. This lesion is also responsible for chronic pain. A number of different types of injuries are also associated with whiplash, including internal disc disruption, among many others. Whiplash causes changes in the neurologic system. So if we have sustained dysfunction in spinal afferents and sustained nociceptive or pain signaling, we'll see changes in the neurologic system that upregulate our pain experience to almost a fibromyalgia-like chronic pain. We have technological shortcomings of our MRI. And so therefore, if we were to evaluate the facet capsular ligaments, a fat suppression technique is recommended, as well as high field MRI. We learned about various effective treatments for whiplash. We learned that electric stim or ultrasound use on a chronic basis is not effective, and it does not reach the injured tissue. We also discussed factors associated with poor outcome pertaining to initial symptom presentation and or activities of daily living intolerances. And those which have severe initial symptoms and severe activities of daily living intolerances usually are consistently having a difficult time at the 12-month post-accident interval and display a significant disability at that point. There's consistent evidence to support that vehicle damage, occupant position in the vehicle, collision dynamics, findings on imaging, or sensory motor deficits are not accurate indicators of patient outcome following whiplash. Additionally, female gender, advanced age, neck range of motion, or whether patients have an attorney are also not accurate indicators of poor outcome. And finally, research supports the use of matched interventions, specifically manual therapies, class 4 laser, neuromuscular therapies, intermittent traction or spinal decompression traction. And these are applied to reduce peripheral and central nociceptive input and chronic pain signaling from WAD. So that concludes our presentation. Hopefully you learned something. And hopefully you will like and subscribe, which I would appreciate very much. Pass this information on to people that have an interest in it, and take care of yourself.